So for anyone who is new to the IKN family or community, my name is Dr. Kyle Paxton, one of the co-founders of IKN. So I'm based out of the DC metro area here in the US. And then we have Dr. Ryan Foley, who's our other co-founder, who is graciously staying up late in Ireland right now. And then we also have Dr. Ryan Flick, who's our lead IKN instructor, who's based out of Houston. So we're all over the place. But the main topic today is going to be talking all things midline and how those training principles can really start to push back on what the traditional thought process is and how we can actually build a much better, more efficient model over time when we're speaking about the midline, and not just in a performance lens, but also how do we bring that into the rehab concept. So we have a couple things that we want to talk about, but like I said, throw stuff in the chat, ask questions, and we'll be chatting here. So feel free to get engaged. Okay.
Mm-hmm.
All right, cool. So, I mean, one of the first things that we were kind of thinking about and how we've kind of come down this path is what you see so much on social media is what like the traditional thought process is for midline training and engaging the core, and how it's really consciously based, and how people even come across the idea that people need midline work. And one of the things that we always say is the importance of assessing and treating midline features versus actually correcting movement, right? So I think that's something that is really important to us at IKN, and understanding what those features of the midline that we should be harnessing are. And when we think about what traditional midline or core training is, it really goes against a lot of that. So I don't know if you guys have some initial thoughts on the idea and definition of midline features, and we can kind of start there.
Yeah. So like the reason we wanted to bring up that first point was because there was a new study brought out. It was last year in a rehab journal, a musculoskeletal rehab journal, talking about the importance of not necessarily clustering our clients around their pain diagnoses. You know, so you have a client come to see you with lower back pain. Is it a facet joint? Is it a disc issue? You know, so you're not clustering them around a client with disc pain, a client with facet joint pain, whether it be lower back or neck-based issues as well, or like a nerve impingement, that type of stuff. But what we need to start doing is we need to start looking at the features that individual displays from a movement standpoint, from a neurological standpoint, but also from a mechanical, anatomical standpoint as well. So when we are in our level 1 course, and even in our level 2 course to a greater degree, we speak about the different body regions, right? So we have the midline, we have the upper limb, and then we have the lower limb. And as we get through this roundtable talk, we'll start to realize how it's very, very difficult to talk about the midline without considering the influence and the interaction of the limbs as well. That's the biggest thing I think that we see on Instagram and with traditional based assessment and rehabilitation, is that people tend to speak about the midline as the midline on its own. Whereas we don't look at the midline within the context of the limbs. And you have to look at the midline within the context of the limbs, because on a moment-to-moment basis, on an everyday basis, it's very rarely that your midline is directly engaging with the environment around you. It's not being directly loaded against the environment. You know, so we would view the midline as being more kind of load insensitive, versus the limbs being more load sensitive, because your limbs are actually directly engaging with the environment. So we have to always step back and have this framework in mind as to how we view the midline. And so we need to have features, and these features are movement features that allow the midline to be robust. What are the qualities? What are the characteristics that allow the midline to be robust? And what we mean by robust is it's what allows the midline to resist perturbations, to be adaptable in the face of uncertainty, in the face of stress. And so when you look into the research, because I think, like, when I look at research now, I always look at it through the lens of our kind of framework. And so one of the key things that you see in a lot of musculoskeletal research around low back pain, for example, is you see a lack in muscle activity of the local stabilizing system, they would call it. So it's just those local muscles like your multifidi, like your transversus abdominis. Like if we're looking at the kind of the lower part of the midline around the low back, for example. So like they've done studies where like if you got low back pain, for example, and you reach with your upper limb towards a target, what they found is that if you are displaying low back pain, that the local muscles, the multifidi, the transversus abdominis, might be slow to react. They might express low EMG activity, right? And so what that has sparked, and that research goes back many, many years. And what that has sparked then is it sparked these rehabilitation or corrective movement strategies to try and get the transversus abdominis to fire properly, or to try and get the multifidi to fire properly. But what that does is it doesn't respect the way in which, or the manner in which those muscles are actually controlled on a neurological level during movement. Because when I think of that, when I think of an individual moving their upper limb, for example, I'm thinking, okay, does the nervous system actually feel comfortable with the upper limb's ability to tolerate load and to manage load when it reaches? And then can the midline display the reflexive characteristics to make sure that you don't fall with that upper limb doesn't take you with it? And so what we can see then is what they've displayed in the research is that you're going to see a dysfunction, they call it, or a difficulty with firing those local stabilization tissues. And so we might see an increase in activity of the global stability tissue. So you might see an increase in activity of your erector spinae, your QL muscles, and so that's what sparked an awful lot of this kind of core training that is very, very conscious. But when we look at the neurology, and we'll speak about this as well, one of the features of our midline is to really understand that there are neurological components to the control of the tissues, but we also need to respect the anatomical features as well. There's kind of features within both buckets, neurological features and anatomical features. And I know we're going to get into those in much more detail throughout the talk, but those features are essentially the characteristics that we want the midline to display. And the thing about features is that they're universal across everyone. They're stereotypical behaviors. It's not like one person's going to need this type of feature, that person's going to need this type of feature. We'll all need certain features to allow our midline to be robust. So you need features that are stereotypical, but there is also other movement features that aren't necessarily extremely important, but they still allow us to adapt. We'll get into that in much more detail as well.
Yeah, I think one of the things you said, even more towards the beginning there, that is almost the opposite of how core training is usually seen, is making your midline adaptable, right? And I think traditional core training is almost the opposite of that, right? Like you're using what at IKN we call these high threshold strategies. We use these high threshold strategies, right? Like think about a plank, or even when you're doing like we're all PTs, me, Ryan, and Ryan here, right? So like when they teach you to do like a single leg deadlift, they tell you to brace before you do the movement. You're really eliminating that adaptability, and that is not a long-term strategy to be able to manage the stressors of gravity. And I think until people understand what some of those neurological principles are and how the neurology is actually controlling the midline, that part's not really going to change. And I think that's something that we try to do, is get people to understand how is the nervous system actually utilizing the midline and how that happens. Because like you said, a lot of the things they do are very conscious, right? Yeah. And I think that's a discussion we can start to talk about. But if you really think about an adaptable midline, it should be just reacting to perturbations, right? Like even like what you said, reaching your extremities, the reason you can't separate is every time an extremity moves, that's a perturbation to the body, right? And your midline needs to be able to respond to that. And by separating those, you start to really limit the carryover you're going to get to the real world. So I think it's changing. I think the idea of what midline and core training is definitely changing, but you still see so much of it on social media that's frustrating, because it doesn't follow, like you said, either the anatomical principles or those neurological principles in how it should be done.
Yeah, it definitely is changing. Like with the research we're seeing coming out now, like we're starting not to get too fixated on local pain experiences. But with low back pain, like what does the low back do? Like, how does the low back move and express itself within the context of the rest of the midline? Or how does the low back express movement within the context of the lower limb? Those are things that we need to be looking at. We need to be looking at local and global principles.
Right. And, I see this in the hospital all the time. I think certain clinicians like cling to this idea of having a diagnosis as if having a diagnosis is somehow going to change their treatment. Like,
exactly, yeah.
And I think that's what medicine has kind of fallen into. They want to classify things and put it into a smaller and smaller box.
Mm-hmm.
When in reality, it's, you can give somebody a diagnosis of, any type, ankylosing spondylitis or whatever it is, but ultimately, like, how is that changing the features and how is that changing the ability of the midline or the trunk to adapt overall? And like, that's what we should be looking at as clinicians is, okay, they have a diagnosis, but what does that diagnosis mean when it's compared to their ability to move or to absorb force or to, to tolerate more complex like movement demand that they're being faced with every day. So, and I see it, I saw it today with one of my coworkers was saying that, hey, it's because your legs are weak. That's why you can't stand up. And I was like, well, we don't necessarily know that, right? And it's like, you can't just test the quads or test the hamstrings, in an isolated test and then say, well, that's why you can't stand up. Because if your midline can't absorb that force and can't tolerate that load and then be able to respond to it and then allow the legs to respond appropriately, then you're not going to be able to stand up either. So I think there's a lot there, and there's still a lot that's missing. But hopefully, in the coming years, as more and more research comes out, people start to pick up on it a little bit more.
Yeah. And it's based on this development of neurology as well. Like when you're a baby and you come into the world for the first time, like you're seeing a lot of erratic movement distally in the limbs, right? That's because, again, you've just literally come into the world and you're dealing with gravity for the first time. So you need to develop the neurological control over certain parts of your anatomy from proximal to distal, And so like you need to build that initial midline conscious control first before we actually interact with the environment distally, right? But I think people are still treating people like babies. We're still treating people like as if they're on the ground. They're trying to get up off the ground using their core and doing all these kind of very consciously driven midline type movement strategies. And while that might be important, we always should have an endpoint, and the endpoint should always be to allow for the distal parts of our extremities to tolerate stress, so that stress can be dampened and dissipated, so it actually gives our midline the chance to stay adaptable. All right, and so what we can get into now, just to move on, we can talk about the key overarching features. And for each of these features, there's many kind of sub characteristics, you can say, but there's kind of four very fundamental features for the midline, from our perspective, from an IKN perspective, that the midline needs to be robust, to be adaptable. So the first feature is that we need to have good quality breath coordination, right? And the reason we need to have good quality breath coordination is because breathing, or the act of respiration, is actually something that acts as a source of constant feedback to the nervous system about the state of the midline, right? And so this is really, really important in allowing the midline to stay adaptable, because it actually means that we don't have to consciously think about what's happening. Because I always have to breathe to stay alive, I'm that movement of the rib cage. So breath coordination means that the movement of air into the rib cage, the movement that we're getting with the rib cage, actually loading the tissues around the rib cage, getting movement in through the diaphragm and all the other associated tissues around the midline. Those are being loaded and unloaded. They're being stretched and contracted with every breath. And that's constantly delivering a source of feedback to the nervous system. So the nervous system always has this subconscious awareness of what's happening there. And that's why holding your breath is not just from a metabolic output standpoint, how much effort you're putting to something, but holding your breath during tasks isn't actually allowing for that second to second update of where the midline is in space. So for us, that's a reflection that they probably lost the ability to coordinate their breath well. Right? We can talk about that in more detail too. The second one is you actually need good quality feedback from all the other tissues throughout the midline too. So the pelvis, the spine, the neck, right? You need good quality feedback from all these tissues too. So breath coordination, good quality feedback from those tissues, from the muscles, nerves, and joints along the midline. Number 3, you need good quality load tolerance through the limbs, right? Because again, if your nervous system doesn't trust your limbs' ability to actually move and engage with the environment, what do you think is going to happen? It's going to probably protect things proximally. It's not going to allow you to dissociate the limbs from the midline. You know, I'm not going to feel comfortable actually reaching outside my base of support, either with my upper limbs or my lower limbs, because my lower limbs anatomically are organized very, very differently. Right? I've got much longer bones in my limbs. And that's why there's a need for biarticular muscles to be able to transmit load across a bigger surface area. But if my limbs can't dissipate stress well, then that's going to lead to a change in the organization of control around the midline, because we're going to have to protect ourselves. Everything's going to be almost retracted. So we're going to see maybe this kind of compression of the upper limb towards the midline, or this compression of the lower limb to the midline. That's why we might see a lot of kind of tension in the upper trap, tension in the lats, you know, or tension around the upper glutes or the lower back, the erector spinae around the lower back, because it's almost like the limb retracts to the midline. And then lastly is more of a top-down feature, which is the load tolerance, or the capacity of the eyes and the vestibular system to be able to tolerate load well, to allow for top-down changes in tone at the midline. Right, so there's lots of things that goes into allowing the midline to be robust. But what we think, if we were to compare this to traditional physical therapy approaches, the one thing that traditional physical therapy approaches look at is just that feature of feedback from the tissues, the feedback from the rectus abdominis, or the obliques, or the transversus abdominis. But there's so much more than that. There's many other features, and that's why we have to look at the midline within the context of the limbs as well. So how about we kind of talk a little bit briefly about the importance of breath coordination?
Yeah, well, I think, that exactly. I think that's where we should start, because what's your guys' opinion, right? So we have all of those features. Traditionally, we always say kind of building that platform for change, right? We really want to make sure the body is ready to accept load elsewhere. And that's why we usually like to start with breath coordination and those types of things. So for people listening, Ryan and Ryan, is that usually where you guys will start as well, with breath coordination first before other pieces? Because we just talked about 4 of them, right? Like, how do you know where to go first?
Yeah, I mean, for me, that's one of the first things I look at. Many times when my clients, you know, in the hospital, when I'm evaluating them, they're in bed. And if they have trouble getting out of bed or rolling over or doing anything, the first thing I look at is, can they even engage their diaphragm? How are they breathing? What's going on? And then work on that before I try and progress to anything else, because it's more likely that they're going to struggle with any type of movement upright if they can't even control their midline. And like Ryan was saying, it's pivotal to be able to engage the diaphragm, to be able to engage the breath coordination, get good rib movement, get good thoracic mobility before you try and do anything else. Because if you don't, all you're going to be doing is reinforcing a poor movement pattern. And you're just going to be getting them up and moving around and trying to move through a reflexively resistive pattern. So I start with that first before I really try and move on to anything else. And unfortunately in the hospital, you know, there are certain things I have to make them do on their first day. Like, they have to get up, they have to walk, they, you know, have to try and go up and down stairs and stuff like that. But, you know, most of my treatment is still revolving around trying to build that ability for the midline to be able to respond appropriately before I start to really focus on more dynamic movement control, like walking or anything else.
Yeah. For me, like I work in a clinic where I'm seeing clients with chronic pain every single day, you know, and at least where I'm from, people come in, they don't expect to lie on their backs and breathe all day long, or even for any amount of time. They want to get to the root of their issue. So for me, the way I organize my assessment and treatment framework, especially if it's a midline issue, I look at it from a standpoint of issues or pain experiences from the rib cage up or the rib cage down. So if an individual has a pain experience somewhere from the rib cage up, whether it be thoracic spine pain, shoulder pain, neck pain, any kind of issue, I'm looking at the capacity of that individual to be able to dissociate the upper limb from the midline. And then what I'm doing is I'm integrating breathing during a dissociation task. Mm-hmm. So I'm not just having them lie on their back and breathe and try and completely relax. I will engage a very low threshold strategy of the upper limb with the midline to integrate that breath coordination at the same time. So so I'm actually allowing for a very clear, I'm creating a very clear intervention that I actually want to achieve, and that's going to help me kind of build upon to the next actual loading strategy. But I'm still getting what I want from a midline feature, but also from a limb ability to dissociate. So if it's a rib cage down issue, whether it be lower back issue, pelvis issue, or any kind of lower limb issue, I'm looking at the ability of the lower limb, to be able to dissociate from the midline. And then I'm integrating breathing with that as well. Right? Because that's the first thing from our treatment framework is, does the client have the capacity to be able to dissociate the limb from the midline? Right? Because you can do all the breathing you want as you're lying down, but when you actually are standing up, I'm assuming that many of the people that you treat have arms and legs. They have to engage their arms and legs. So they have to be able to breathe while they engage an arm or a leg. So you have to be able to integrate that, even if it's in some very, very, very low level capacity, just to bring their awareness to the limb initially, and then breathe. That's incredibly important for me. And then it builds that kind of that therapeutic alliance with the client, because the client doesn't come in. The client has expectations to come in and get their pain sorted. They don't want to come in and just breathe. They want to experience some kind of load. And we need to stress them as well. We need to stress them while we relax them. We don't just relax them, because ultimately they're going out into the world where there's lots of stress. The world is full of uncertainty, full of chaos, and full of unpredictable forces always acting in your body. So you always have to, for me anyway, when working with people with pain, I always integrate the limbs with the midline breathing first. Right?
Yeah.
It goes deeper than that, but
I think that's such an important concept for people to understand too, because it's such a simple change off of what they're probably already doing that can give so much bang for their buck, right? Like, I think a lot of people understand that breathing is positive for midline issues, but they don't look at breath work through the right lens, right? They think of it purely as either an oxygen exchange or this like parasympathetic activity. And well, yes, those things are happening. When you can just start to add that extra lens on, the carryover is so much more significant. Because like you said, as soon as they stand up against gravity, they're now being stressed, right? If you're not carrying that over, even like you said, at a really low threshold, the carryover or that jump just is never going to happen. And I think that's why, like, especially like when we got out of school initially, even back, I mean, when we were in school, people understood that, yeah, start a session with breathing, right? So like there was some sort of concept that's powerful and helpful to kind of help self-organize. But when you really can start to understand these other features, right? The importance of that disassociation with the limbs, or the importance of these top-down features, that's when you can start to add that piece. And it's such a dynamic change in your practice. But I'm right there with you. I think if you can find an entry point with that low threshold strategy with the extremity, it's so novel to the person as well that it really starts them to have to force to build that awareness in a much different way. And I think that if people can take something away from this breath coordination section, it's that idea of finding a way to disassociate as quickly as you can, just making sure they're using those low threshold strategies. And maybe this is a good clarification. Like, what would you guys consider like a low threshold strategy versus a high threshold strategy? Because I think those terms are new for some people.
Mm-hmm. Yeah. Like initially it's very, very important to understand that when an individual, like we're seeing people in pain,
Yeah.
so you need to consider that their system has felt the need to protect. Their higher brain centers have felt the need to express a top-down form of protection. So it's not just about loading the system with any kind of load. We need to use more of a consciously driven load. And so we use a lot of isometric strategies initially, but we can actually subdivide isometrics into different strategies where we're actually either producing force or we're resisting force, we're tolerating force, we're sharing forces. So producing force neurologically, and Ryan, you can kind of delve into this as well, is that when we're producing force, it's more of a consciously driven activity because you're actually in control of what's happening. Whereas when you're resisting force from somebody, you're responding to someone else. So you don't know how much force they're going to deliver to you. So it's more of a subconscious activity. And sometimes that's too much stress for an individual. So we use more what we call like overcoming isometric strategies initially, because it provides a platform to allow the client to experience load on their terms, but also slowly builds tension over a certain range. Because usually what you'll find is that when clients are in pain, they're just fighting. They're fighting forces. They're fighting gravity. So you notice this with your muscle testing as well. That's why we don't do an awful lot of that classic muscle testing of muscles, isolated muscles, because when an individual is in threat, they're just trying to fight everything. So they're moving from 0 to 100 with no understanding of what's in between. They can't estimate force as well. So using an overcoming strategy where you're building tension very, very slowly from 10%, 20%, 30%, 40%. And it could be 10% of your maximal voluntary contraction that you're doing initially. But the key is actually doing it in a distal to proximal strategy. So you're not just we need to understand that when you're doing breathing, you need to have a point of orientation. And the point of orientation, which allows you to navigate the whole treatment and rehab process, gives you that endpoint. So let's say we have somebody with neck pain, we have to understand initially that there's probably not really a massive importance of looking at the lower limb initially there, right? But again, there's an importance of looking at how the neck is organized within the context of the actual upper limb. So we want to use the hand as a point of orientation of what experiences load, because that's usually what actually integrates or interacts with your environment directly. So that's where we're going to have the clients slowly build that tension, produce that overcoming isometric strategy, right? And I know, Ryan, you know an awful lot more than me about the actual deeper neurology of what's happening.
Yeah. So
point, right?
When you think about conscious motor output, like conscious control, what the research shows is that that's driven, and there's a lot more activity in the primary motor cortex. So when you think about the primary motor cortex, you should be thinking of that motor homunculus, that weird looking guy. And if you look at the motor homunculus, the hands, the feet, the head, they all have a much greater representation. So just from a metabolic standpoint, and a neurological standpoint, it's much easier to consciously control those areas because there's a much greater representation. And that's sort of how, when we talk about structuring these different approaches, why you always kind of orient the movement and the isometric through the distal extremity and through the hand and through the foot. Because if you have more conscious control, more conscious awareness of those areas, it makes it a lot easier for your brain to start to engage those areas. And then there are different parts of the brain, different parts of the subcortical structures, the brainstem, the cerebellum, that are, more active during reflexive control, or, the more proximal structures during engagement. So, if I'm in, again, somebody mentioned a plank earlier, right? If you're in a plank position, or if you're in any type of like holding an isometric, if wherever your intention is focused at, whether it's through your hands, whether it's through your feet, a lot of people feel it right in their midline immediately, and they feel that engagement. And I think that's why planks are so difficult, because then you start to bring your conscious focus, your conscious attention to your midline, when the midline isn't really meant to be consciously controlled. It's very metabolically inefficient. And the nervous system really can't handle firing that conscious output as much as it can through the hands or through the feet. So then you fatigue very quickly and you see people like sitting there shaking, right? And it's because the nervous system doesn't know how to like orient or coordinate that motor output or that neurological output. And it just becomes a very inefficient movement. So when we talk about isometric loading and we talk about putting it, bringing your awareness through the extremity, it's really so that you can take advantage of that like natural tendency for the brain to have good conscious control and good conscious awareness of the distal extremity, while just letting the more proximal structures be engaged reflexively by those systems that are meant to reflexively control it. The midline cerebellum, the more rostral, the more anterior parts of the brain in front of the motor cortex, they're really responsible for helping structure that proximal control based on our intent and based on the demand being placed on the body. And then when you see somebody in pain, or you see somebody who is, struggling to coordinate motor output, whether it is again for pain, or you just notice there's tone, or you're working with an athlete who just can't seem to move efficiently, or it's just not a coordinated output. Again, that's a sign that those parts of the brain aren't coordinating output as well, and they're protecting the body for some reason, or they're putting the brakes on movement for some reason. So if we can take a step back and start to structure our approach so that we're taking advantage of the way the brain is kind of designed to fire and designed to help modulate that movement, we can really start to get it to work a little bit more efficiently. And you can start to see movements start to become a lot more efficient very quickly.
And also like trying to understand how the central nervous system offloads workload into the body as well, right? So like, how does the nervous system take advantage of our anatomical system so it reduces workload? And so you look into the research as well around this kind of distal to proximal gradient of control, and you'll come across many research papers around like ankle injuries and distal radius injuries, or hand fracture type injuries. And what you'll see is that you'll see an awful lot of compensatory strategies or increase in muscle tension and tone proximally. Right. And so when you think of, let's say, an ankle injury, when it comes to the foot and the ankle has to do an awful lot of work, right? So it has to be able to manage the mass, a huge amount of mass of the rest of the body as you move through the world. And so if you have some kind of ankle injury, ankle break or ligament sprain or anything like that, do you think your nervous system is going to feel comfortable tolerating stress and load through that area? Or is it going to change its movement strategies to maybe shift the load tolerance more proximally? Now, that's a helpful initial strategy because it offloads the ankle, but what it can lead to potentially is an excessive expression of tension proximally. So we might see that like excessive tension up around the upper glute or around the lower back, right? And so we might be thinking to ourselves, we need to stretch the hip, we need to stretch the back, we need to get a core firing. When actually what we need to do is we need to get the nervous system more accepting of tolerating load through the distal extremity. And by doing that, we're actually offloading the proximal structures as well.
Yeah.
Right. And that's why doing that through distal extremities, distal to proximal loading is extremely important because it offloads the workload of the nervous system.
Right. No, you're 100% right. And I think too is somebody doesn't necessarily even have to have an ankle injury or ankle pain. If somebody just has developed or never developed a very efficient strategy, and then they start to go to run, they want to start exercising again for the first time, then the force from them running and hitting their foot on the ground over and over and over again, if their body doesn't have the ability to absorb and distribute forces appropriately, their nervous system will perceive that as threatening, and that can cause that same sort of reflexive tightening in different areas. And it can cause just that different presentation. So it doesn't even have to be pain. I see it with a lot of my clients that they'll just have ankle tightness. So they'll say, well, this ankle just feels tighter than this ankle. And, there's a ton of different treatment approaches. There's a lot of different stuff out there as far as like, how do you approach this? And it all kind of comes back to getting the nervous system to feel comfortable, allowing more range of motion and more accepting of that load. So again, somebody has low back pain, somebody has hip pain or tightness, or they just feel like they can't move like they're supposed to. Again, looking at the lower extremity as a whole, or the lower half of the body as a whole, and figuring out which piece isn't falling into place like it should.
Mm-hmm. And even think of it from a standpoint of like just managing your mass, like you said, like whether it be walking or running. Like when you're walking during gait, there's a certain amount of time where you're on one leg, and your whole body is suspended over one leg. So do you really want your ankle to be nice and loose and floppy in that scenario? Or do you want it to be responsive to the load, to be able to be responsive to the ground reaction forces acting from the ground up, so that it can handle and distribute that stress well? If it doesn't have that capacity, what might have to keep you upright or manage your overall mass? You're probably going to do it with more of a proximal strategy. And in neurology research, they look at this from like an ankle strategy or a hip strategy, right? During kind of everyday walking, we want to be using more of an ankle strategy, because from a definition standpoint, you really, like, ankle strategies are responsible for more kind of low load perturbations during walking. Whereas if somebody shoves me, I might have to use a hip strategy, but I shouldn't be using a high threshold movement strategy to walk down the street. Like if I'm trying to push someone off, like if I'm a soccer player and I'm in a game situation, I might have to use those kind of strategies. But that's why I'm only playing soccer for 90 minutes and not for 24 hours a day, or however many days you're up and about, like that you're not sleeping. So it's all about managing and like you said, Ryan, taking advantage of how the central nervous system distributes workload and offloads workload into the body, but not just looking at it from a midline standpoint, but how does the midline interact with the limbs as well and with the environment? Because like we said at the very beginning, too many people just narrow their focus far too soon at the midline. How do we get the core firing? And even with breathing as well, like sometimes breathing is not the only thing. Like breathing is something that's important, but we always have to distribute that load where we want it in a way that actually respects. Because when we talk about those features at the beginning, we're not just pulling those features out of the sky. We've kind of put those features together based on this interplay between neurology and the mechanics and the anatomy. So it's all based on neurology. It's based on musculoskeletal care, but we're trying to put it into a framework that really allows you to have a little bit more kind of focus when you're actually working with a client with any kind of midline based issues. What do you do first? Where do you go then?
Yeah, and I think as we're talking about really taking that step back look and distributing load, we've already talked about some of the breath coordination stuff, right? We've talked about how the limbs as a whole need to be able to accept that load and distribute it. Otherwise, we're going to have that protective kind of high threshold strategy from the midline. But one of the other features we talked about that is usually one of the kind of newer features for people to understand is how the eye and inner ear work from more of a top-down perspective. And I think that was one of the biggest things that we started with at IKN. And one thing we tried to do is try to blend that bottom up and top down interaction, because you can't really just focus on that feedback strategy, right? And I think that's where a lot of people get caught up and work on that really conscious control midline stuff, working on getting those tissues to feed back to the brain. That's important. But let's talk a little bit about kind of that top-down strategy and how the eyes and inner ear, both from a conscious perspective by seeing something and reaching for it, and a subconscious kind of reflexive perspective, more protective strategy, how the inner ear can be involved as well.
I think using like a research article to describe this as well, it will be helpful. And this is one that we use with our level 1 cohorts as well initially to describe this importance. But there's a research article, we can post it on Instagram as well, that talks about how when an individual loses the ability, and it could be after an ankle injury, when they lose the ability to express good quality ankle strategies, because again you're upright on 2 feet, managing your whole mass with your foot and ankle. When they lose that capacity, what will typically happen is they will use more of a hip or a low back strategy. And that's where we might see an individual maybe express that kind of splinting at the spine. You know, they start to move maybe into what looks like more of an anterior pelvic tilt position. Because when you move into an anterior pelvic tilt, then you're going to move into more spinal extension. When you move into more spinal extension, you're moving into more of a closed pack position of the spine. When you move into more of a closed pack position of the spine, you're reducing variability. And that's what you want when you're not feeling like you can't manage your mass well. You want less variability, which is good short-term wise, but it's not good long-term. So if I'm moving my body into more of a closed pack position where I'm kind of splinting and I'm freezing the movement potential there, for example, am I actually giving my eyes, my head, and the rest of my body the opportunity to actually couple from those segments or to dissociate from those segments? Because when we talk about the eyes, we talk about the eyes as being the fifth extremity. We spoke about already where we want the limbs to be able to dissociate from the midline, but we also want the eyes to be able to dissociate from the midline as well, particularly the head, because that's extremely important in allowing for the top-down distribution of reflexive tone into my spine, particularly into the extensors, right? So you can even see this from like an old ankle injury. You lose ankle strategy, you start to use more of a hip, low back strategy to manage mass. When you kind of run out of compensatory reserves there, what they tend to see in the research is an individual will become much more visually dominant, where they'll actually start to need to look at wherever they're moving. So you see this kind of rigidity in the movement of the spine. You don't see that ability to dissociate. Right. Yeah. So initially, I think people think for neurology, let's just get the eyes moving and fire the vestibular system. But it's really initially just about getting that dissociation, the eye and head coupling ability. Can the eyes go one way? Can the head go the other way? Do they actually have the ability to do that in slow motion? And then we can add speed. I know, Ryan, you can get a touch on that as well.
You know, and just to go back to your point where you're saying, you know, when somebody has, that presentation where they have to move their whole body, like go into any nursing home or any hospital where somebody's trying to like walk after a knee replacement or a hip replacement, and they are staring directly down at their legs and their feet, trying to figure out what's going on, right? So yeah, that's pretty common. But I completely agree. I think, and you see this a lot online where people are just doing sensory drills just for the sake of doing them. And you know, when we're talking about vestibular drills, and we're talking about the one-time viewing vestibular drills where, you know, you have your target here and you're turning your head and keeping your eyes on that target. I mean, from a neurological standpoint, what that's really doing is activating more of the cerebellar cortex. And that's important because what happens when you have these high tone, these tightness in the midline, these patterns, is that the nuclei and a lot of the systems in the brainstem are very active in increasing the tone there, because again, it's subconscious, it's reflexive, it's happening automatically, but the cerebellar cortex helps to shut that off a little bit. So it's inhibiting that tone. So when you're doing that VOR, you're activating a very complex pathway that is helping engage the cerebellar cortex. And when you see somebody struggle with that and somebody who can't do that, what that's telling you is that they're having trouble in engaging that system. And that's just going to show you that there's a lot of feedback there trying to keep that cerebellar cortex off as a protective strategy. So when I try and do VOR with somebody and they just can't get it, they cannot keep their eyes focused on the target, and their eyes keep coming off, I'm like, hey, we got to do something else here before we jump into VOR, because your system can't handle that even a little bit. So I don't get them in a sitting position or a lying down position, because again, that's not structuring, you know, we're not getting the brain to coordinate what we want it to coordinate, which is tolerating load through the extremities when you're just lying down. So I get them to start trying to tolerate load through the extremities in a lying down position rather than maybe a standing up position, because if they can't do VOR and standing up, we need to do something that they can do to try and get those tissues to start absorbing load a little bit better before I jump into the vestibular stuff. Because doing it too early, or at a time that or in a modified position, it's not going to have the same effect overall.
And you have to do it on top of a platform of like, what did you do from a bottom-up standpoint first? Because when a client comes to see you, they don't expect to do. So for people who don't know this, VOR is the vestibular ocular reflex drill. So you're just getting the eye and the head to decouple.
Right.
But like we have that treatment framework that we have to apply every case to, and that we want to go from the bottom up first. We want to understand how the brain takes advantage of the anatomy first, building that load, respecting neurology from the bottom up, and then many times we don't even have to get to the eyes in the inner ear. Perhaps they're pain-free, or they have a high level movement capacity even without doing that. But it's something that we can get to improve or increase that movement capacity as much as we can.
Interestingly enough, there's some cool literature to show that the vestibular nuclei themselves, they get most of their input from systems other than the vestibular apparatus. So they are getting a ton of information from the eyes. They're getting a ton of information from the cerebellum. They're getting a ton of information from the peripheral tissue, actually from the muscle spindle fibers go up and activate, the descending or vestibular nuclei. So there's a ton of other systems that you can utilize and leverage before you kind of like jump into these sensory systems and just do a sensory drill because you're just trying to do a visual drill or vestibular drill because you saw it. Like you said, engaging the tissue first and building that platform is absolutely crucial.
Exactly. And any monkey can do this, like with a client, right. Understanding like, when do you do it?
Right.
Why are you doing it? That's the key thing. Like everything's done before, but it's understanding how does that fit within a model or a framework to navigate the complexity of an individual.
And to be honest, if you do something, I mean, these systems are very powerful too. The visual system is hugely powerful. If you do something the wrong way and somebody, that can make things worse. That can increase tone or it has the potential to make things worse. So, or push somebody over the edge.
Comes into play. You got to assess it first, and then we load based on an assessment. But
go ahead. I was just going to say, I see it with concussion patients all the time. They don't realize they've had a concussion. They were in a car accident, airbag deployed, They're like, well, I was never told I had a concussion, but now I haven't been able to focus for the past 6 years. And, if you're doing visual vestibular drills and you're not a little bit more specific with them, that can, they have a headache, they have a migraine, they can't function for the next 2 or 3 days. So these things are really powerful.
So because I want to talk about like a very classic assessment that we might do for a midline case, let's say, for example, you have somebody with lower back pain. Okay. And we want to take a look at how the midline as a whole moves, or how the lower back moves within the context of the midline. And one of the most common things you'll have somebody do is bend down and touch their toes, right? Now, people will always say, okay, what's going on there? But they'll look at it purely from a muscular standpoint. What muscles need to be able to kind of unload or relax to be able to get you down there? But the muscles aren't the things that are actually engaged first. Like when you go through a forward flexion or to touch your toes, you're essentially falling forward. Yep. You're literally falling towards the ground. You're taking a very important piece of gear, your skull and your brain, and you're literally pulling it towards the ground. That's not something that the brain's going to just step back and say, "Oh, just go ahead and do that." It's not going to take it very lightly. So when you're going forward, we spoke about how like when you move into extension, the spine will move into more of a closed pack position. So that's safe. That's why you might see people in that kind of splinted posture. But when you move from extension to flexion, now you're all of a sudden moving from that closed pack position to an open pack position. So now all of a sudden there's lots more variability at the spine. So what happens now is that the brain needs to be able to, one, trust the lower limbs' ability to decelerate your body going towards the ground. And so if you don't have very good ankle strategy, if your ankles aren't responsive, you may see that increase in tone in the spinal extensors. Right, so from a bottom-up standpoint, that can be something that's important. But also, when you're falling forward, then what's the first thing to activate from a top-down standpoint? The vestibular system, because it's going to pick up that head movement as you go forward. And so if your vestibular system can't tolerate load well, or pick up that direction, that change in movement direction, what do you think is going to happen? We might see an increase in protection at the midline. And so it's not just about like I said, getting the midline tissues moving more by getting breathing going, by working on breath coordination, by getting better feedback from the midline. But it's also looking at, right, what's happening below the midline, what's actually holding up the midline. And that's your lower limbs. You don't see anybody walking down the street on their midline, on their hips, on their pelvis. You see it from the limbs up. And the top
right.
down.
And one of the other things too that you have to consider as well, especially when somebody has increased tone in their low back and they're in that extended kind of low back or closed pack position, right? There are a lot of different systems that there's a protective system that's kind of facilitating that position, right? But once you're in that position, there are other systems in your brain that are picking up on that. And they're saying, wait, why are we in this position? Well, we must be falling forward if we're in this position. So then if you try and force yourself to consciously go into that position, it could make things worse because there are so many subconscious systems that are saying, wait, we're already falling forward. Don't do that more. Like, why are you making us go forward? We're already trying to hold you into this position. So again,
you have to stretch the hamstrings. That's all you got to stretch the hamstrings. Pull out the rope and just lie on your back and stretch the hamstrings. You'll be fine. But no, that actually leads us into a question.
Yeah.
Sorry. What do you guys think about mobility, stretching? Does it work in general? I think the important thing to understand there is that why are you doing mobility and stretching? Because if you, let's say, for example, somebody has a tight hip, and they maybe have a little bit of hip pain. Now, if that individual is in pain, we have to understand that, again, we can't just throw mobility at that hip or stretching at the hip. We have to understand, how does that hip, or maybe it's a low back as well, how does that hip and low back move within the context of the entire lower limb? And using those qualities that we spoke about already, is the hip actually tight, or is it expressing more protection because the limb actually as a whole can't tolerate load from distal to proximal, right? So if we just go in and throw a lot of mobility and stretching at the hip, for example, but we haven't assessed the lower limb's ability as a whole to handle stress and handle forces, then we could be stretching the hip for the rest of our lives.
Right?
Every single day, getting a bit of temporary relief. But that means that it doesn't mean that does it work is a very kind of loaded question. But we have to understand when is it important to do? When do you do it? Do you do it at the beginning? I would say that if an individual is expressing pain, what I typically find clinically is that it's not that the area is locked down, for example. It's that you're seeing an excessive amount of muscle activity because the nervous system has felt the need to restrict that motion because it doesn't feel your body has the capacity to handle stress. So get the individual better able to handle stress first, and then whatever's left over, then we can actually maybe see, okay, maybe they actually do need a little bit of extra mobility or stretching around that area. So it's about when is it important. But the important thing to understand is that, like, if you're someone who just has a tight hip and you don't really have any pain, and we're not seeing them from a clinical standpoint, then it's probably not going to cause any harm or any issues. But if you're in pain, you have to understand that your system is currently feeling the need to express a lot of tension and protection in the form of pain. So we need to prove to it that it can handle stress first before just opening up range.
Right.
No,
I agree. And I see this with a couple of my clients who are very flexible. They were gymnasts or dancers, and now they're trying to go into, that's how they stayed active their whole life, was with that kind of activity. And now they're trying to work out, or they're trying to run, and they don't have a lot of good coordination. They don't have the ability to control the tissue. So it's not necessarily, it's again, can you structure coordinated output, and can you have a robust movement pattern that can handle the load being placed on the body? That's how I view mobility work is, am I going to be helping the tissue absorb load that's going to be meaningful to the client? Somebody just had a total knee replacement and they only have 15 to 30 degrees of range of motion. I'm going to be doing some stretching. They need to have just general tissue, a range of motion, like passive tissue range of motion. But again, from that kind of perspective of pain, I completely agree. That's kind of where we're going.
We have one question. We'll finish up on this question here, I think, from Fit and Bendy. with hyperlordotic clients, how would you address that issue with the brain already thinking that you're falling forward, asking for a friend? So I would use the exact same framework as we've been using already. I wouldn't jump to the brain first. I'd understand what does the brain need in the body to not have to work hard to stop you from falling forward. How does the nervous system offload workload into the system? And so if they're hyperlordotic, I would want to understand, do they actually feel comfortable handling stress in the lower limb? Because maybe they're going into the hyperlordosis because they're trying to move into a closed pack position and limit variability. Right? So maybe that could be a top-down reason for it, or there could be a bottom-up reason for it. But even just by shifting workload into the lower limbs, you're reducing the workload of the brain, because you're actually getting it to do the protection for it. Because the brain just thinks in terms of protection and survival. It's always kind of estimating the capacity of your body to handle stress. And so if you can handle stress from distal to proximal through the lower limb, you might see those strategies at the lower back. And then you'd work through dissociation strategies first, just allowing the lower limb to handle stress without the midline having to contribute with excessive tone around the midline. And then you're building through those layers, tolerating stress from distal to proximal. And then if you get to the point where, okay, you assess top-down systems and you find a lot of inability for the eyes and the inner ear to handle stress well, then you would just merge that on top of the bottom-up stuff that you've already done. Right? So it's not about saying, okay, people with hyperlordosis always have this part of the brain that's not doing its job well. There's no homogeneous or uniform lack of activation in every client with hyperlordosis. You know what I mean? It's about slowly building through a process, right, from bottom up and a top down standpoint, and then assessing to see how it.
And I think that's going back to what you were saying earlier. Is like you can't put people in this box and say, well, this is your diagnosis, so this is your treatment, kind of thing, right? It's assessing what their ability is. Yeah.
Assessing the features. Do they have the features? That's the beauty of it, is that you have somebody with neck pain, mid back pain, shoulder pain, hip pain, pelvis pain, lower back pain. You're thinking, do they have these features that need to be expressed to allow for them to handle stress well? And then you merge those features with what we call local features. So those would be everything we've mentioned so far. We would look at them as more global features, but then you have local features. So in the context of low back pain, you might use the global features that we've spoken about already, but a local feature might be this really fancy technique that you learn in a course, where it's not a feature that the system actually needs to be robust, but it's something that might help deliver some better feedback from a local structure, from the hip or from the pelvis. So that will be something that we see as not necessarily universal, because you could have low back pain and you check the hip and they could be lacking internal rotation. The second person that comes in might be lacking external rotation. You're going to use a different local strategy for them, but the global features will still remain the same, because we all have midline and limbs, most of us anyway, unless you're working with amputee population, it's going to change. But that's why it's so important to separate global from local features. What are the stereotypical features? We want the universal features across every human. And then what are the local things that we can merge with that? And it's having that framework then that takes them through a process of building that robust movement, Yeah.
And I think that's the biggest takeaway to take from all of this is understanding those global features. Because if you're going to address something that's going to give you the most bang for your buck, that's drastically different than what the majority of people are doing out there, is really understanding what those are, right? And that's feedback from the midline, right? That's breath coordination, right? That's our ability to coordinate our limbs and really distribute load through them appropriately and disassociate. And then that's our ability to have our eyes and inner ear with that top-down mechanisms, right? So those four pieces are four pieces that unfortunately traditionally aren't really thought about except for midline feedback, right? So I think if you can start to branch your thoughts into understanding those features, and there's 1,000 different interventions to target each one of those, right? I think it's less about a specific intervention, like we've said. And I think that's a lot of the questions we get, like, oh, okay, in this presentation, like what exercise should I do? If you can understand the features, you can be creative to start to target those systems. And as always, your ability to be creative is usually what separates a good therapist from a bad therapist, right? But it's the understanding. I think anyone's going to take stuff away from this, that's what it should be. And we talked about a couple studies in here, and I think, like Ryan said, the studies really are starting to trend more to this, and it's definitely the future. So doing your best to try to understand it now as it continues to evolve and start to merge it into those local strategies you do is what we're trying to do at IKN, right? Give you that next step to bridge what you're doing to these more global strategies to get change, not just faster, because I think it's not necessarily about faster, but building robust humans to be able to manage the stressors of the real world. And that's where a lot of therapy misses. So we certainly appreciate all you guys listening. Any last words from Ryan Squared over there?
Ryan Squared. No, I just want to say thanks to the guys for that are going to stay up late to listen in, and those that ask questions. And it's a pleasure to speak to you guys. And hopefully, if you have questions, again, feel free to email us or DM us on Instagram.
Yeah, thanks again. Thanks for having me, guys. Thanks for staying up and listening, guys. Yeah, and DM us anything. Yeah.
And last shameless plug here, since Ryan was kind of the deeper neurology guy on this talk, if you've already taken our courses or do a lot of this kind of practical neuro stuff already and like the deeper understanding of the why that's happening or the how that's happening, Dr. Flicks here are going to be having a course drop with us at the week of the 21st. So today's the 10th, so just under 2 weeks. So if you are interested in that, stay tuned. It's going to be pretty awesome, and it's going to be our most affordable course yet. So stay tuned for that. We're going to be blasting out emails about it. Or if you're not following us on social media, make sure you are, or make sure you're subscribed to our email list to stay up to date on that stuff. Otherwise, this is Roundtable number 2. We plan to do more things like this. So if you guys have other topics that you're interested in, let us know, because we want to build these for you guys, right? So let us know things that you might want us to chat about, guests that you might want us to bring on. We want to do more of this in the future. So certainly stay tuned for more roundtables.
Cool.
Awesome, guys. Thank you for listening. We appreciate it.